do you want me to repeat, or?
I'll summarize really quickly. So for those of you listening to the recording, apologies, I forgot to turn on the recorder. We're talking to Susan Johnson, who's a first-time caller, and calling on behalf of her husband, who had a Gleason 8 and participated in a trial of 6-month chemo and hormone therapy prior to radical prostatectomy. And that's where, oh, and where was he treated? Did you say Ventura General Hospital?
Vancouver General Hospital, the prostate center.
Okay, Vancouver General Hospital. And Susan, please go ahead.
So after the treatment and the prostatectomy, his PSA went down to undetectable for about 14 months, and then it became detectable at 0.05, and then it took about another year and a bit over a year to go up to 0.1, and then almost 2 years before it got back up to 0.2, which is where it's at as of now. It actually had gone to 0.23, and then it dropped to 0.22 and 0.20. The clinical trial, he has PSA tests every 3 months, and he sees the doctor, his surgeon, in fact, that did the original surgery, every 6 months. So it's actually dropped down since what it was in December, but it's still over 0.2, and now the surgeon, who is also the head of the prostate center in Vancouver, recommending hormone therapy for 9 months, and in the middle of it, radiation to the prostate bed as the best chance of a cure. And I've been now back into doing the research because I'm the researcher in the family. My husband finds it quite just daunting and depressing to have to read all of it, and so I've been a consultant for a number of years, and so I'm kind of used to jumping in and reading a lot of stuff and trying to pull out the salient points. We're now at a stage where he has to go. Tomorrow we're seeing the medical oncologist again, and Thursday we're seeing the radiation oncologist, and we're going to see what they say, but there's people who've been kind of saying things like, well, you shouldn't have waited this long to have had the radiation. You should have had it the moment that things became undetectable again, and who knows where it is now. It's probably out there somewhere in the... So it's we're getting a little bit of fear and doubt. And that's kind of where we're at, is that, and I got onto the US2 forum and onto other forums and researching with the idea of trying to get as much information about what's state of the art at this point with a recurrence that to me seems like it's not really fast. It's not doubling at a rate of 2 or 3 months or anything. But people keep saying yes, but as soon as you get over 0.2, you have to do something. You can't just not do anything, and it has to be radiation, even if that's got bad side effects from salvage radiation. Anyway, so that's where I'm at.
Right. Just a couple of questions. What was Grant's PSA before he was treated? What was the highest it got to?
It went up to about 12.
Okay.
And then he started the chemo and the hormone treatments, and it steadily dropped to the point where before the surgery, it was down to just over 1.
Okay.
And then it went down to undetectable.
And was it rising really quickly right before he started anything? I mean, did it go from 8 to 12 in 6 weeks, something like that?
No. What happened? We were living overseas, and he had it tested in 2009, early 2009, and it was just under 4. And then where we were living, they didn't actually say, well, you should have that tested every year because it's kind of getting a bit high. And so for 2 years he didn't have it tested, and then went in to have it tested, and it had a DRE, and they found the lump in December of 2011. And at that point, this PSA had gone to like 9 or 10.
What was he staged at?
They said Gleason 8, 4+4.
Yeah.
And by the time they finished the prostatectomy, they said that the treatment that he'd undergone made it impossible to assess the tumor's Gleason score anymore.
And what was the T stage that they gave him? Was he a T2B or was he a T3A?
Well, the radiologist thought he was a T3, and the surgeon thought he was a T2, and that it didn't really matter.
Well, it does matter.
I know, but
because
in terms of the treatment, when they did the prostatectomy, they said it had not escaped into the seminal vesicles. It was no positive margins, but there was one periprostatic lymph node that had evidence of cancer.
Okay. And one last question before we sort of get into some discussion. I'm curious if you'd be willing to, I'm curious who your doctors are.
The doctor that performed the surgery is Dr. Martin Gleaves, who is, and the other surgeons we consulted were much less experienced, but he's quite experienced and one of the best in Canada.
Right. And
that was the carrot for the clinical trial, was that the surgery would be done by someone who had done a lot of those surgeries and therefore less likely to cause permanent injury.
Right. And the medical oncologist?
His name is Dr. Kim Chi.
Yeah, I know who that is. Yeah. How did you like him?
Do you?
How did you like?
We really liked him, and he was effectively the person that got us signed up for the clinical trial. Okay. Because my husband is very, very healthy.
Yeah.
But they had what they considered to be an aggressive cancer, which might have, in fact, spread past the prostate at the time of the starting of the trial.
We lost a guy 2 years ago. Paul, what was his last name, guys? Come on, somebody can help me here. Paul, the French-Canadian guy that lived in the mountains up in Western Canada.
The skier.
Yeah. What was his last name?
Yeah. It'll come to me. I can't remember it off the top of my head.
Began with a P, but he did not like kimchi at all.
Paul Picard. Picard.
Picard, that's it. Paul
Picard, yeah.
Yeah, he was in a trial with him, and he really didn't like him. And I don't know, maybe there was no chemistry. But then I've had other people down here and around who have joined the call who have liked him. So I think it might have just been an individual thing, but the chemistry certainly wasn't there between him and Paul Picard. Paul did an early trial with Xtandi and Zalutamide with kimchi, if I remember. I'll go. I'll look. But yeah. So I'm going to let Peter, who moderates our low and intermediate call, but I'm going to let him take over for a couple of minutes for a very good reason, which you quickly learn. Peter, do you want to talk to Susan a little bit?
Sure, Susan. I live in Hawaii, and I was treated in San Francisco because I wasn't comfortable with the medical procedures here. But oddly enough, I had a very similar situation and treatment protocol as your husband is going through. The only difference was I've never had chemo. I was not on any kind of chemo trial. They didn't recommend it. This was 3 years ago when I was diagnosed. I was diagnosed with a Gleason 9, and it had advanced beyond the prostate and invaded my seminal vesicles. So I knew that up front. So the difference is, which is an unusual thing, and similar to your husband's, I was put on androgen deprivation, Lupron and Casodex right from the get-go. That was my first modality of treatment before I did anything else. So I had ADT, androgen deprivation, up until my prostatectomy, I guess, which is similar to your husband's. And I'm assuming he stopped the androgen deprivation after his is prostatectomy, although that might be an assumption. It might not be right. But anyway, I did 6 or 7 months of ADT before my prostatectomy. And then it was a year. I lasted a year. I knew I was probably going to have to go back for radiation, and I made it for 11 months before my PSA climbed to 0.2. And with the agreement of my oncologist and my surgeon, both in California, we agreed it was time to go through radiation. I chose to go back to San Francisco because, again, I didn't trust the radiation expertise at my home, in my own local hospital. So I planted myself there. Now it's been just a little over a year now since I completed my radiation, 39 treatments of IMRT, and at this point I'm side effect free. I came out of my prostatectomy completely continent with no problems. I mean, I did have some, odd bowel things and stuff from the radiation and so forth, but it all cleared up within a number of months, and I'm pretty comfortable and satisfied now. I'm waiting till tomorrow to find out. I just had a blood test yesterday, but I have blood tests every 2 months, and so far my PSA has been undetectable for the past year, and it's been fine.
Mm-hmm. How old are you?
So, I turned 70 in July. Okay. I was diagnosed when I was 67.
Yeah. My husband was 62, and he's now 68, just turned 68.
Right. So my word is that I wouldn't be too fearful of the side effects of radiation. Some people do get side effects. As long as the facility at Vancouver is really good, that they check with them to see how much of their work is actually prostatectomy. The reason I didn't want to do it here in Hawaii was because most of the work they do is breast cancer and other cancers, and even though your husband's prostate's been removed, when they radiate to the prostate bed, like with me, I mean, everything else is right down there. Your rectum is right there, your urinary tract is right there, your bladder is right there, and you want to have not only a doctor, but technicians that run the machinery that really are on top of their game at the best there is going, and you want to make sure the machinery is pretty new too.
Yeah, and that's the sort of thing it's hard to assess if you're a layperson. They all are going to say, oh yes, we're great. There aren't really any places that, any comparative sort of statistics and really good information sources, unfortunately. But one of the things we're considering with that is that we actually live about, probably an hour out of Vancouver, and there is a cancer center. It's the same agency, the BC Cancer Agency, and there's a cancer center where we live. But I'm concerned that maybe, and my husband's concerned that maybe that it'd be better off to just make the commute into Vancouver for the radiation, just in case, because they're going to be, perhaps the technicians will be more practiced at the prostate center than they will be at the general cancer place in where we live.
I would think so. I'd check into that carefully.
That cancer center in Vancouver is pretty good. They participate with a lot of the American, the U.S. NCCN hospitals in various trials. I think they may even be in some way, shape, or form associated with one of the dream teams, or one of their staff is on a prostate cancer dream team. So they have a really good rep. I'm assuming that your insurance really requires that you get treated in Canada. Is that right?
Yeah, that's basically it.
Yeah.
We have provincial medical insurance which wouldn't cover anything in the U.S. Okay. I mean, one of the things we're truly grateful for, the chemo was obviously brutal, docetaxel, right, at the same time as the hormones. So we weren't sure in some cases where all the side effects were coming from, but it was really brutal. But at the end of it, the fact that it's been 5 years before it's gotten back to 0.2, I think, was a great thing. And the fact that we're in that system, in the sense that the head of the prostate center is his surgeon, and he's, knows Chi, and they know us, and they have a lot of researchers there. So the hope is that they will be able to kind of assess what's really the best treatment now for him, and what state of the art, so to speak, that we can actually achieve in Canada.
Well, one thing that you should really be well aware of, and as you listen to this call after we finish speaking, you'll hear it, is that the way that you cannot contemplate cure per se at this point. It's really unlikely that your husband would ever be cured, but there's a very strong likelihood he could get a durable remission or even manage this disease for many, many, many years. And so the name of the game is to get the most out of every phase of treatment. And every day there are more phases of treatment and there are more trials. I mean, we have in this group, they're not, I haven't looked in the last 5 minutes. When we started talking, they haven't joined us yet today. Oh, yes, they have. Thibaut's on the line. Who are really going cutting edge treatment. It couldn't be more cutting. So every day we learn more about this disease. I mean, since I was diagnosed back in 2007, we've probably gone 180 degrees around the circle in terms of the way that we're treated. It's very interesting that your husband went on this clinical trial with chemo, because we had a very dear member of this group and a close friend of mine, Dominic Moresi, who passed away just about a year ago, last June. And he did a similar trial back in 2005. He had chemo, I think it was right after his radical prostatectomy, I think, if my Len's not on the line, so I can't check that, but I think it was right after. Now, he had aggressive, pretty rampant disease. He was a lot younger than his husband, and he lasted 11 years after his treatment. And I'm sure some of that was because of the early chemo. And we are now moving much closer towards the breast cancer model, where we treat disease that we consider to be possibly locally advanced or advanced with chemo very early in the, rather than using chemo as a palliative treatment. I mean, in my own case, I had locally advanced disease, and at the time that I was diagnosed, I asked for chemo, and they said, well, we don't think it makes much difference. I think today, they still might not be ready for somebody with locally advanced disease, but they certainly treat men diagnosed with advanced disease with chemo very early in the cycle. Let me throw it open to anybody else that would like to talk to Susan, and then we'll come back to you, Susan, with any final questions. Anyone else have any thoughts or can relate to Grant's situation?
Susan, how does he do on ADT, on hormone treatment? Is he able to tolerate it okay?
He basically went through the equivalent of the menopause, which actually made him sympathetic to what I'd gone through, a few years ago. I was sympathetic because I knew exactly what it was like, but otherwise it wasn't horrible. The chemo was the horrible part, but no, the hormone therapy was just Lupron. He wasn't on multiple hormones, I don't think, and it was only 6 months. And then he had about a month to recover before the surgery, because we didn't want to have the surgery right after the chemo stopped. He needed time to recover. So we're not really scared. We're not really scared.
They might put him on Casodex this time as well as Lupron. If he goes through radiation, it's a common thing to start you on Casodex as well as Lupron. you say he's in good shape. Well, tell him to stay in good shape. You know, get it, join a gym, do whatever you can to get exercise, because that's essential. It's the key. It sounds like a broken record. We tell each other sometimes, but it really makes a huge difference. If you can, you know, drag your butt to the gym or do whatever you do for regular exercise, it makes a huge difference in the way you tolerate the androgen deprivation, particularly in with the radiation.
Yeah, the combination. Yeah, it's you know, we get some exercise but not enough, and part of the problem is we have a fairly significant travel schedule, which we're trying to now cut way back this year to allow for the treatment.
Right.
But yeah, I do know that getting him fit is going to be key.
Yeah, make it a priority.
It's really it's important not only that he does aerobic but also some weight resistance exercise. We have you can take a look at a website called themanplan.com, which is
the Man Plan.
Yeah, which is sponsored by AbbVie, who make Lupron, and they have a home-based program that some of our guys are on, and you combine that with walking every day, and however much travel you're doing, you know, you've always got time to take a 15-minute walk, and
yeah,
it is a habit that it's essential you get into. 6 months of Lupron is very different to a more extended period. There are guys who have been on Lupron here for years. I myself was on Lupron for 30 months. And it catches up with you. And the better physical shape you're in, the less impact it's going to have. So, you know, the three things that you can control are exercise, diet, and stress. And those three things you have to make a commitment to. We'll send you some information if you let us have your email address. Either you can give it us online or you can send it to me at my email address, RD, R as in Rick, D as in Davis, RD at ANCAN, A, N as in Nancy, C as in Charlie, A, N as in Nancy, ANCAN.org. If you send me a note with the, you know, coming from you, then we'll add you to this distribution, and I'll send you a couple of UCSF pamphlets, one on nutrition and one on hormone therapy, which you'll, I'm sure, find very useful. You may even be able to get your husband to read the hormone therapy one. It's pretty.
Yeah, we've actually got a book. We got a book by Richard Wassersug.
Yeah.
Which had quite a lot of useful information.
Yeah, and it's very good. I know Richard.
Yeah.
He's local to you.
He is. I'm hoping to meet him at some point.
Yeah, he's pretty available. You should reach out to him and send him a note. But what you'll find is that this hormone therapy pamphlet, it actually preceded Richard's book by about 3 or 4 years, and it's a lot shorter. It's about 40 pages long, so it's a little more concise. It's not quite as thorough. It doesn't have as many references, but it is written to be read by people who don't know much about hormone therapy that are facing a significant period on it. So I'd like to move on only because we've got another gentleman, another new guy. What I encourage you to do is to keep coming back, because you'll learn a lot. Ask us questions. Bear with us. I've got people I can hook you up with in Canada that might be very helpful to you. We have a lady that lives in Toronto whose husband has been in a similar situation to Grant's for must be 5 years now. And I would be happy to connect you to her. She's very friendly and outgoing and very knowledgeable. but we can really help you. Let me ask to close out. Do you have any other questions you'd like to ask us?
I guess since we're going to be seeing the medical oncologist tomorrow, Dr. Chi, is there any question that sort of pops to mind that we should be making sure we get an answer out from him?
Well, I mean, what I would say, and I'm going to turn this to Peter and anybody else that has questions, but what I would say is you want a game plan from him. You want to know when he plans to intervene, which might be there and then, or if he doesn't plan to intervene, when he does, and what his reasoning is. As you heard Peter say, 0.2 is on recurrent disease. 0.2 is a pretty good number. On the other hand, Peter Carroll and others at UCSF have been known to wait until 0.4 or 0.5 if the disease is very slow moving. And your husband's disease is pretty slow moving. So they, you know, if she says, look, you know, it's taking such a while to creep up to 2, you know, why don't you just wait and see where you go? I mean, I would definitely recommend, we don't give medical advice, but we do suggest things you can talk to your doctor about. And one thing is getting tested more often than every 6 months. I think you know, if it were me, I would be wanting to keep a closer eye on this disease, and I would want to get tested at this point at a minimum once every 3 months.
Well, 3 months. 3 months is the interval that he's been on. It's just that he's only seen the doctor every 6 months.
Okay, fine. All right. Well, yeah. So you know so that would be my suggestion, to get a game plan. Peter, what would you wanting to be asked, Dr. Chi?
Yeah, a game plan of an idea how long a treatment plan he has in mind. You know, whether he's thinking 18 months or 2 years. What the duration of the ADT, because your husband's already done 6 months and now he's been off for a while. So you might want to go for another 18 months. So that's often standard. It's hard to say, but ask him those kind of questions. Ask him about whether he plans to use Casodex in conjunction with Lupron. Ask him about you know, more aggressive treatment sometimes. You know, what his feeling is with that, with Zytiga or Xtandi later on if you start failing something. So be upfront with him. You know, get a feel for how aggressive he is with his treatment, or not.
And the radiation. I'm not sure who ends up sort of supervising the treatment. If he has radiation and hormones sort of combined, should it still be under the medical oncologist?
I would suggest so. I do that. I kept my medical oncologist separate. I have a private one separate from my university radiation oncologist, because they have my medical oncologist is far more aggressive in his treatment. My radiation oncologist was kind of you know, not really big on I mean, he used the hormone treatment, but he wasn't, he didn't see it as an important part as much as the radiation. And so it's why in your team, and talk to them both, and just find out what their approach is, how aggressive they are in terms of treatment.
Yeah, let me.
So it still sounds like go ahead.
Let me chime in on that. I would strongly encourage you to try and stay under the direction of Dr. Chi during the hormone treatment, because hormone treatment is systemic, and radiation oncologists and neurologists are not treated are not qualified in internal medicine. And you really need somebody who understands internal medicine. So while the radoncs and the surgeon and the oncologist, the urologists like to hold on to that treatment, I don't believe it's the right way to go. So I in the I'm in the camp of very much of trying to get hormone therapy supervised by a genitourinary medical oncologist.
Mm-hmm. Yeah, I think we're thinking that we probably we feel comfortable enough with him, and he knows all the history, so having him kind of be the lead, and then obviously the radiation oncologist, depending on where we end up with it, it may be a different one than who we're going to be seeing, because it might be that we'll decide that we want to go to Vancouver for it. It's a little tricky to say, well, can you give us your resume and have you got any references to the guy out where we live? But if it comes to that, I'm prepared to be, I guess, impolite.
Okay. All right. Well, let's move on. Please send me your email address. We'll add you to the distribution, which means you'll get a note every time before every call. Usually
Okay.
I have other information in those calls. And our next call will be next Monday. Tuesday. Our next call will be this coming Monday at 5 o'clock your time, 5 o'clock Pacific.
Okay.
And
we'll have lots to report.
Okay. Great.
Thank you so much for the advice.
Fine. Stay on the call if you wish, or whatever. We'll be talking to a bunch more people about probably a lot of different things today. Let's move on. And Gary, can you hear us, and are you with us at this point?
Yes.
Good. So you kind of heard the routine. Would you give us a quick background on your situation, your disease demographics, your age, where you're being treated, and what brings you to this call, and so we can talk about you.
Okay, I'm from Spokane, and I was diagnosed with, I had a biopsy in November and had cancer at that point. So I just made a decision. All I've had is a urologist, a surgeon, and I just made the decision to do a radical prostatectomy right then and there.
Mm-hmm.
The biopsy said I was a Gleason 7, but after I was done with the surgery, they said the pathology report put the cancer at a Gleason 8. Mm-hmm. I've been undetectable since the surgery, except I'm still dealing quite a bit with incontinence, so that's been a real struggle for me.
Well, let me first say we would love to help you, but I think you probably should be on Peter's call, which we held yesterday. Since you don't have, while you have high-risk disease, you're not on hormone therapy right now. Or have you ever been on hormone therapy?
No. I'm brand new to the whole calling in here, so I just thought, well, I'll check and see and which group I might fit in best with.
So Peter, I'm so glad you're on the line tonight. We're working you over.
Yeah, I can only be on for about another 40 minutes or so. Okay. Anyway, yeah, incontinence is a tough one. When did you have your surgery, Gary?
It was in December.
Okay, and this is about 6 months out. Has your incontinence been tapering off somewhat, or is it about the same, or is it more intense? What's happening there?
Well, I thought it was getting better, and it just slowly seems my sphincter, I guess, is getting better all the time, a little bit. But I have stress incontinence, so if I lay down or sit down, I don't have any issues at all. But sometimes I like to get a lot of exercise, and whenever I go exercise, that's when I have my issues.
Right. Are you doing the recommended Kegel exercises and so forth?
Oh yes, absolutely. I'm doing my Kegels all the time. So.
Okay. Yeah. So I mean, some people struggle with this. I don't have an answer for it. You know, if it continues for, you know, into a year or something, you know, some people go through medical procedures to take care of it, but oftentimes it does taper down and become more manageable, and something you can work with. I'm glad you're exercising. You know, play around with your diet a little bit. So what you're drinking, when you're drinking it, and so forth. You know, try to stay away from things like coffee or alcohol or whatever that might have some effect on it. Some guys have experimented with that and found some effect. It's a nuisance. It's a real nuisance, and unfortunately, the doctors don't tell you how often that happens. So you've just worked with your urologist, no other medical people on your team at this point.
Yeah, I guess I'm not very smart about this whole process, and all I've had was a urologist, and I just said, let's do it. I didn't go into a whole bunch of, I did go try to see if I could have another meeting with another urologist, but they made it very clear that within the same city, if you're with somebody, we won't see you. So it was kind of a weird thing, and I'm not sure how that all works to even get a second opinion. How do you even do it without offending your doctor and all that stuff? So, but anyway, it's done for me.
Yeah. Sometimes you got to offend your doctor. That's what I've learned.
Right.
I mean, this is your health. This is your life. I mean, there's small things you could do. As you say, you were upgraded to a Gleason 8. You might want to have your pathology sent to Johns Hopkins for a second opinion. You know, and just, you know, make sure everybody's reading things right, and get that Gleason 8 confirmed, because there's a big difference between a Gleason 8 and a Gleason 7, particularly if they originally said it was a 3+4. You want to make sure that there's no spread. You know, have you talked to anybody about any scans or anything like that, bone scan or anything like that?
No, I haven't.
Well, Peter, let me interrupt you. To me, as long as Gary's looking at an insignificant PSA, less than 0.1, and I want to come back to that in a second, Gary. I am not, personally, I am not in favor of doing a whole bunch of tests, because I don't think it changes your treatment plan. If, on the other hand, you're trying to figure out what treatment to get, or your PSA is rising, I think a lot of this makes good sense. But if you're stable, the only problem is, have they been doing a sensitive or an ultra-sensitive PSA test, or have they been doing a regular PSA test?
As far as I know, it's a regular PSA test. And I just go in and have them draw my blood, and I don't know. Right. Ultra-sensitive.
And do they report it as 1 decimal place or 2 decimal places?
The last one, I got my first one, I think, was in February, and now I just went in for another one, but the last one was a 0.03.
Okay, so if they're doing, that's an ultra-sensitive test. So that's going to give you a pretty good indicator. If it moves up a little or down a little, don't worry, because it's not totally accurate. But it's going to give you an idea. If you go from 0.03 to 0.09 in a short period of time, there's an issue and you need to intervene. If, on the other hand, you go 0.03 and then it's 0.05 next time and then it's 0.04 the time after that, that's probably noise. Where are you being treated at Kaiser?
No, I'm being treated at the Deaconess Clinic.
Okay.
here in Spokane.
Okay. So, you know, while Peter gives you good advice, I always say, what difference would it make to your current treatment if you had that information? And I'm not sure it would make any difference for your current treatment. So your issue sounds to be one of incontinence. I really encourage you to participate in Peter's call, which the next one will be a week on Monday. What date is your next call, Peter?
2 weeks from the 9th. What's that, or the 8th? 24th?
27th or the 28th. I don't have my calendar. Whatever it is.
23rd or 24th. Whatever the Monday is. The Monday after next.
Okay. So, and the reason I say that is because there are guys on there, the guys who are dealing with issues like you are more likely to be on that call. And there are tricks and things that they do. Would you say that your incontinence is just a lack of control, or is it urgency?
It would be both. Sometimes there is urgency, but sometimes it just decides. You know, I actually, when I have urinated, you know, emptied my bladder, so I don't have a whole lot of pressure in my bladder, that's actually when I really have incontinence the most. If I have a full bladder, it kind of holds, but that's what I'm struggling with.
The reason I ask is because there are some good drugs out there too that might help you. Detrol is one. There's another expensive one. The name doesn't come to mind right now. It begins with an M, but I can't think what it is. But there are drugs, and you might want to try using those drugs a little bit. At the same time, a lot of it is just relearning to use your muscles. And some guys, it just takes longer than others. So
I have an appointment to go in next week to start biofeedback. Okay. Do you know anything? What's that about?
Good. That's good. It's a technique to try to regain control over your bladder and sphincter. It's used. It's not commonly used, but there are many doctors that try to do that, and it's useful. Some people have found it very useful.
Yeah.
Okay.
And I would also add that there's some electroacupuncture that also that was originated by a doc at UCSF, and I know people that have had great success with this electroacupuncture. It takes about 6 or 8 sessions to kick in, but it's worked well. And again, if we'd be happy to connect you, see what happens with this biofeedback. But again, please let us have your email address so that we can send you advice when the next calls are. I would send a note to Peter K, P-E-T-E-R-K, Peter K, at ANCAN, A as in Alpha, N as in Nancy, C as in Charlie, A as in Alpha, N as in Nancy.org. I see you're on the web, so I'll put it in the chat window for you in a sec.
Oh, okay, good. Thank you.
And, you know, I would say keep coming back to this call, but I just, you know, this call we deal with some issues that may be intimidating to you, and you don't need to hear them. And so you better fit Peter's call.
Well, I'm not afraid of that.
Okay. But then
I'm not afraid of that.
Okay.
Actually, I really appreciate the fact that I can hear other people, because I feel I've been really alone in this. So, and I just haven't known anybody that's going through this either. So I appreciate hearing what other people say.
Well, then what I would say, is to join both calls. Then send me and Peter. My address is rd@ancan.org. This is Peter K@ancan.org. And we'll put you on both lists, and you're very welcome to join us as often as you like.
Okay, thank you.
And
Rick, this is Jake.
And we have to put a plug in for a couple of other things. We have an inner conversation call, which is an emotional support call, which Jake's going to tell you about momentarily. And we also have, we ask you as a minimum to, we ask you to at least sign up for Amazon Smile if you're an Amazon user, because we benefit from that every time you make an Amazon purchase. It doesn't cost you anything, but we get 0.5 cent. So if you go to amazonsmile.com and you nominate Answer Cancer Foundation, it helps us. Well, of course, you're always welcome to make a donation to the 501c3 too, but we don't require that. Nor do we, for that matter, require that you sign up for Amazon Smile, but it just doesn't cost anything. So, Jake, do you want to talk a little bit to Gary and anybody else about your Inner Conversations call?
Yeah. Well, first of all, Gary, the next low risk meeting that Peter was talking about is the 22nd.
Jake?
Oh, can you hear me?
Yes, yeah, I've put it on my calendar.
Okay. There was saying the 23rd, 24th.
Is anybody else
the 22nd. Everybody can hear me.
We hear you, Rick.
Rick, everybody can hear you. You just can't hear us.
But anyway, I wanted to extend an invitation to Gary and also to Grant. On this Thursday at 8 o'clock Eastern Time, we have a session called the Inner Conversations, men only. So it will be